Today we're going to be focusing on something you probably don't think too much about until it starts to cause you trouble, that is.
Yeah.
We're talking about the wrist. And even more specifically, we're going to be untangling the complexities of something called carpal instability. Now
Okay.
you're probably thinking, oh, my wrist. Okay, sure. But it's more than just a simple sprain. It's really about what happens when those tiny but oh so important bones in your wrist, the carpals, they kind of get out of whack, they lose their alignment. And today we're going deep into the mechanics and the often I'd say silent control systems that make your wrist, as flexible and strong as it is.
Right.
So that's what we're here to do today. We're going to try and give you a clear understanding of carpal instability. What are the things that can trigger it? And then the amazing ways that your body actually tries to keep everything working smoothly in that really, really intricate joint. So maybe to kick things off, you can help us define carpal instability. What exactly are we talking about here?
Well, simply put, it's when the way the bones in your wrist are supposed to be arranged and work together, it's lost.
Right.
And this usually happens when those ligaments, those strong like bands of tissue that hold the bones together get damaged. And so when this misalignment happens, it just throws off the smooth, efficient movement of your wrist. And so, people might feel pain, swelling, or they might feel like their wrist is giving way. That's the instability part.
Right.
And of course, that limits how you can actually use your hand. You could think of it like a set of gears that just aren't meshing properly.
Yeah. It's like messing with a well-oiled machine,
Yeah.
but in a very subtle way,
Mm-hmm.
but with significant implications.
Mm-hmm.
And what I find really fascinating is that there isn't just one thing that's responsible for keeping this stability.
Mm-hmm.
Our sources talk about three key components. So first, we have static stability, right?
Mm-hmm.
This is really just about the way the bones fit together
Mm-hmm.
and the inherent strength of those ligaments themselves. They're kind of the passive restraints.
Yeah, exactly. Then you have dynamic stability, and that's really where the muscles come in.
Ah,
They're constantly working to make little adjustments and to control the movements and positions of your wrist bone. So it's always happening.
so it's always working. And then, to me, the most intriguing part is this idea of neuromuscular control.
Mm.
This is where your body, I guess, has its own internal sense of where your wrist is in space. That's proprioception. And then these feedback loops between your wrist and your brain. It's incredible.
Yeah.
This is how, I guess, you can instinctively, catch a ball without even thinking about it, without having to look at
Yeah.
your wrist.
Right. Yeah.
We even have a diagram here showing how these three, the static, dynamic, neuromuscular, they all work together. It's kind of elegant.
Yeah, it's pretty amazing. And so then of course the question becomes, what throws this whole system off? What are the things that actually disrupt this balance? And the sources mention several common causes, what we call etiology.
Yeah.
And overuse is a big one, right? Repetitive motions that strain the wrist over time. Fractures are another one. They can damage ligaments, or they can actually change the structure of the bone, leading to instability.
Right. And it's not always just like a sudden injury, is it? There are other sort of underlying things that can make someone more susceptible.
Exactly. You have rheumatologic conditions, like rheumatoid arthritis is a good example. It can weaken the ligaments and the structures that support the wrist joints, and that makes them more prone to this kind of instability. And then there's Kienbuck's disease, which is, it's less common. But what happens is the lunate bone, which is one of the carpal bones, it loses its blood supply.
Right.
And that can throw off the mechanics and lead to instability.
Right. Now, we mentioned earlier that carpal instability might be more common than people realize.
Mm-hmm.
So let's talk about the numbers here, the incidence. What's really interesting to me is how it often goes unreported because it's often linked to or kind of overshadowed by
Mm-hmm.
other injuries.
Right.
Like we said, a big percentage, 30.6% of people with the distal radius fracture also have some degree of carpal instability. So even after that fracture heals, that underlying instability could still be causing problems.
Exactly.
So that's something to think about. If you've had a wrist fracture, you might want to, consider if there's something more going on.
For sure, for sure. And when we look at, foosh injuries that fall on an outstretched hand, which is a super common way to hurt your wrist,
Yeah, classic.
the research shows a pretty interesting breakdown of the types of carpal instability that can happen. So scapholunate instability, we'll get into that a little more later, accounts for about 24%. Lunotrigartial instability, also about 24%. And then you have midcarpal instability at about 14%.
Okay. So most of the instability after a Fuchs injury is happening within those carpal bones themselves.
Yeah, and it's not just falls either. Even with general wrist trauma, you see about 10% leading to paralunate instability, which is where some of those carpal bones dislocate around the lunate bone. And what's interesting is that number goes up to 19% in wrist sprains where there isn't a fracture. So it suggests that those ligament injuries alone can cause a lot of these instability problems.
Hmm. Okay, so it's definitely more common than you might think. Now, our sources outline a way to classify these different types of carpal instability. And this is based on the work of Cooney and colleagues, and it seems like there are a few main categories.
Right, yeah. This classification is super helpful for organizing these different patterns of instability. So the big difference is between carpal instability dissociative or CID
Okay.
and then carpal instability non-dissociative, CIND. It's basically whether the instability happens within a row of wrist bones or between the rows.
Okay, so within a row or between rows. So let's
Yeah.
start with CID, the dissociative kind. What's the key thing there?
So CID, it happens within a single row, either the proximal row, that's the one closer to your forearm, or the distal row, which is closer to your hand. And it usually comes from an injury to one of those interosseous ligaments. Those are the tough ligaments that connect the carpal bones to each other. And the two main ones we look at are the scapholunate interosseous ligament, SLIL, it connects the scaphoid and lunate bones,
Hmm.
and then the lunotriquetral interosseous ligament, or LTIL, and that one connects the lunate and the triquetrum.
Okay, so we've got those two main ligaments, and those names they're a mouthful, but they're clearly very important. Let's talk about the first one, scapholunate instability. You mentioned that's the most common.
Yeah, that's right. So, in a healthy wrist, when it's under load, the scaphoid and lunate bones, they move in a coordinated, almost opposite way to keep things stable. So the scaphoid kind of flexes or bends forward while the lunate extends or bends backward. But when that SLIL is torn, that synchronized motion is lost. And so the scaphoid ends up flexing way too much without the lunate extending properly to balance it out.
Right, so I can see how that would definitely lead to a feeling of instability, maybe some pain. What are some of the typical symptoms someone might experience with scapholunate instability?
So they often have pain on the back of the wrist, like the dorsal side, and on the thumb side, the radial side. They might also have clicking or popping in the wrist when they move it. And a lot of times they'll notice a decrease in their grip strength because the mechanics are just, they're off. And actually, we have a diagram here that shows this uncoordinated movement between the scaphoid and lunate when that SLIL is
That's
damaged.
interesting. Yeah, it really helps to see it.
Mhm.
Okay, so what about the other important ligament in CID, the lunotriquetral? What happens when that one gets injured?
So, lunotriquetral instability, a lot of times it's from a direct blow or trauma to that part of your palm below your pinky, the hypothenar region, especially when your wrist is turned palm down, pronated.
Mm.
And when the LTIL is damaged, the scaphoid's natural tendency to flex, it affects the lunate more than it should.
Okay.
And so you get instability between the lunate and the triquetrum. And on an X-ray, what we call an AP view from the front, this can disrupt what's called the Jalula arc. That's a smooth curve that those proximal carpal bones make.
Right.
So if that arc is broken, it can be a sign of LT instability.
Okay, so those are the dissociative ones where the problem is within the row. Now, what about the non-dissociative, the CIND? How's that different?
So in CID, the instability is happening between the rows. So between the proximal and distal rows, or even between the radius, the forearm bone, and the proximal row. Our sources list a few types: midcarpal instability, that's between the two rows; capitalunate instability, between the capitate and lunate; and then trigetrohemet, which is between the triquetrum and hemet.
And what usually causes this kind of instability between the rows? Is it different from those ligament tears we saw in CID?
Yeah, so CIND is often associated with this generalized ligament laxity. So it's a looseness or like hypermobility in the ligaments throughout the body. It's more common in adults, and it can be there without any specific injury, though of course an injury can make it worse. So rather than a tear in a specific ligament, it's more like an overall looseness that lets the rows move abnormally.
Okay, so it's less about a tear in one spot. It's more about a general looseness. And it looks like the classification system doesn't stop there. There's also something called combined carpal instability, CIC.
Right.
So what's that about?
Yeah, so combined carpal instability, it's when you have both CID and CIND in the same wrist. And this usually happens from like high energy trauma, bad fall, or impact, something that damages multiple ligaments and structures in the wrist. And there are a bunch of subtypes: dorsal and palmar paralunate dislocations, where those carpal bones dislocate around the lunate either backward or forward.
Hmm.
Then there are fracture dislocations, where you have a broken bone and a dislocation, and axial dislocations, which are more like a lengthwise disruption of the carpal bone. So they're definitely more complex and serious.
So those sound like they involve a lot of force and damage. And then there's one more category, adaptive carpal instability, CIA. This one sounds like the instability is a result of something else, not just a ligament injury itself.
Right, exactly. So adaptive carpal instability is when the instability develops because of something going on outside of the carpal ligaments. A classic example is a malunion or non-union of a distal radius fracture.
Okay.
So if that radius bone doesn't heal properly, it changes the way the proximal row sits and moves. And that leads to instability, either at the radiocarpal joint between the radius and the carpals or at the midcarpal joint between the two rows. So it's like the wrist is adapting to the bone being out of place, but that adaptation causes instability.
Like a chain reaction almost.
Yeah, exactly.
The body's trying to compensate, but the compensation leads to another problem. It's amazing how interconnected everything is. So with all these different types and causes, how do you figure out what's going on? What does the evaluation process look like?
Well, it really starts with a good history. The
Yeah.
clinician's going to want to know exactly how the problem started. Was it a sudden injury, a fall, or something gradual from repetitive motions? How long has it been going on? What kind of instability are they feeling? Is it like a catching a click or just a sense of giving way?
Right.
Where's the pain? How bad is it? What's the range of motion like? Is there swelling? Do they have good proprioception, that sense of where their wrist is?
hmm
And are there any specific movements or positions that make it worse?
So the patient's description is really important. And then what about the physical exam?
So there are specific tests to check carpal stability. Our sources mention a few, like the pseudo-instability test, the Watson test, which is also called the scaphoid shift test, and the pivot shift test. These all involve the examiner, carefully moving the patient's wrist in certain ways to see if there's any abnormal movement or if they feel pain or instability.
So you're looking for those subtle clues. And then, of course, there's imaging to see what's happening inside. What kind of scans are used for carpal instability?
It depends. X-rays are usually the first step to see if there are any fractures or obvious misalignments. Then MRI is great for visualizing the soft tissues, the ligaments, and cartilage. So that's really helpful for identifying ligament tears. Ultrasound can actually show how the wrist moves in real time, which can help spot subtle instability patterns.
Oh, interesting.
CT scans give you more detailed bone anatomy, which is useful for fracture dislocations or bone problems. And sometimes, in certain cases, a bone scan or scintigraphy might be used. But from what our sources say, wrist arthroscopy is often considered the gold standard for diagnosis.
Okay.
It's a minimally invasive surgery where they put a tiny camera into the wrist joint, and that lets them directly see the ligaments and cartilage, so you get the most accurate view of the damage.
Okay, so once you have a diagnosis, what are the treatment options? How do you get things back on track?
So there are two main categories of treatment: conservative management for the milder cases, and then surgery when it's more severe, or if the non-surgical approaches haven't worked.
Okay, so let's start with the conservative side.
Yeah.
What kind of non-surgical treatments are used?
So for less severe cases, they often start with immobilization, a splint or a cast.
Right.
That takes the stress off those injured ligaments, lets the inflammation go down, and hopefully helps with some healing. And then you have things like NSAIDs, which are non-steroidal anti-inflammatory drugs, and cold therapy to manage the pain and swelling. Physical therapy is super important. They'll work on restoring range of motion, strengthening the muscles around the wrist, and importantly, improving that proprioceptive awareness.
Right, that sense of where your wrist is.
Exactly. And there are specific exercises for that to help the wrist relearn how to sense its position and movement.
So it's like retraining the brain.
Yeah. Bracing or splinting might be used for ongoing support, and sometimes they might consider injections of corticosteroids or platelet-rich plasma, PRP, to reduce inflammation and maybe help with healing.
Okay, so it's a multi-pronged approach. And then when do you move to the surgical route? When are those options considered?
So surgery is usually for the more severe cases, like when there's a significant ligament tear or when the symptoms just don't go away, even with conservative treatment. And the specific procedure will depend on what's going on, the type and extent of the instability. Arthroscopy, which we talked about for diagnosis, can also be used to repair torn ligaments or even to reconstruct them using grafts.
Okay.
Sometimes they do a ligament transfer where they use a tendon from another part of the body to reinforce a damaged ligament. And then for really severe chronic instability or when arthritis has developed because of the instability, they might need to do a fusion.
Mm-hmm.
That's called arthrodesis. They basically join some of the carpal bones together permanently. That creates a stable, pain-free wrist, but you do lose some range of motion.
Right. So it's a trade-off.
Yeah.
Okay, so it seems like whether someone has surgery or just conservative treatment, physiotherapy and rehab are going to be really important. What are the main goals of rehab for carpal instability?
So the main goals are to get that range of motion back, reduce any pain, get the alignment and balance back between those carpal bones, and ultimately just get the wrist and hand working as well as possible so they can get back to their normal life and any sports or hobbies they like.
So it's getting back to doing the things you love.
Hmm.
And how do physical therapists work toward those goals? What kind of techniques and exercises do they use?
They use a lot of different methods, really tailored to the person and where they are in their recovery. So, strengthening exercises for the muscles around the wrist and forearm are huge. That helps with the dynamic stability we talked about.
Hmm.
They might use electrical stimulation like 10NS to manage pain. Splinting might still be used for support. And they'll also work on ergonomics, teaching people how to use their wrist and hand properly to minimize strain, which helps prevent the problem from coming back. And of course, those proprioceptive exercises are essential. That's all about retraining the wrist's awareness. The goal is to get that stability back, not just through muscle strength, but through improved neuromuscular control, that unconscious coordination that keeps the wrist stable while it's moving.
So it's really about retraining that mind-body connection. And that brings us back to that third component of stability, the neuromuscular control and proprioception really is important.
Yeah, for sure. Let's talk about that a little more. Neuromuscular control is that involuntary coordination that keeps your joints stable. And then proprioception is that sensory feedback that tells your brain where your wrist is and what it's doing, even if you're not looking at it. It's like your body's internal GPS for movement.
Okay, so the wrist has its own little sensory network constantly giving feedback to the brain. Where do these signals come from?
So a lot of it comes from special sensors called mechanoreceptors, and they're actually located in the wrist ligaments themselves.
Wow, in the ligaments.
Yeah, we're talking about Ruffini corpuscles, which mainly tell you about the joint's position. Then you have Pacinian corpuscles, which are super sensitive to changes in pressure and acceleration.
Mm.
Golgi-like receptors, which respond most strongly at the extremes of motion. And then, of course, free nerve endings, which are best known for pain, but they also play a role in proprioception. We actually have a diagram here showing how these different mechanoreceptors are spread throughout the wrist ligaments.
That's amazing. It's incredible to think about all those tiny sensors working all the time. And what nerves are involved in all this communication between the wrist and the brain?
So, several nerves that go through the wrist are involved in both controlling the hand and wrist muscles and in sending that sensory feedback for proprioception. We're talking about the median nerve, the ulnar nerve, the radial nerve, and the musculocutaneous nerve. But when you look specifically at the ligaments, some of them have a lot more nerves than others.
Okay.
The dorsal radiocarpal ligament, DRC, the dorsal intercarpal ligament, DIC, the cephalotriquetral ligament, and importantly, the scaphoulinae interosseous ligament, SLIL.
Okay.
Those all have a really dense network of nerve endings. And we have some innervation maps that show exactly where these nerves are in the ligaments.
So it's not random. The ligaments that are most often injured in carpal instability, like the SLIL,
Yeah.
they have the most sensors.
Right.
So it makes sense that your body needs to know if something's wrong in those key areas. So how does all this information get from the wrist to the brain? What are the pathways?
There are two main ones. First, you have the spinal pathway. This is the express route. So the signals go straight up the spinal cord and connect with motor neurons in the anterior horn. And those motor neurons send signals right back down to the forearm muscles. And that creates a quick reflex-like muscle contraction if there's any sudden instability.
So that's the rapid response system.
Exactly. And then you have the supraspinal pathway, which is a bit slower, but it gives you more conscious awareness of what your wrist is doing. These signals go through the spinocerebellar tract to the cerebellum, which is like the control center for movement, and then up to the sensory and motor areas of the brain, where you become consciously aware of your wrist's position and movement.
Right. So there's the fast automatic response and then the more deliberate conscious one. That makes sense.
Yeah. And the sources also talk about the reflexes between the ligaments and the muscles.
Oh, right. Tell me about that.
So there are these direct connections between the mechanoreceptors and the ligaments and the muscles in your forearm. For example, if you stimulate the SLIL, it activates both the flexor and extensor muscles in the forearm within like 50 to 150 milliseconds.
Wow, that's fast.
And what's really cool is that the antagonist muscles, the ones that do the opposite action, they actually activate even faster, within 20 milliseconds.
Wow.
And that helps to stiffen the joint and prevent any excessive movement.
So it's like a really fine-tuned balancing act.
Yeah.
And when we talk about proprioception in rehab, are there specific types that are especially important?
Yeah, there are a few key ones. First, you have kinesthesia, which is basically your sense of movement, whether your wrist is flexing, extending, or rotating. That comes mainly from sensors in the muscles called muscle spindles. Then there's joint position sense, or JPS, which is your ability to recognize and copy a specific wrist position. And finally, maybe the most important one for stability is neuromuscular control itself, which relies on that unconscious feedback to anticipate and react to forces and prevent injury.
So it's not just about strength, it's about control and coordination. And that makes sense why rehab after a wrist injury, especially with carpal instability, focuses so much on retraining these senses. What do those rehab protocols look like?
They often start with conscious proprioceptive exercises. So things like trying to match different wrist positions with and without looking to improve that joint position sense.
Okay.
There's also something called TTDPM, target task displacement perturbation matching, where they move your wrist passively and you try to match the movement with your other hand.
Interesting.
As you get further along, they'll start focusing on strengthening those muscles around the wrist and forearm. That provides that dynamic stability. And they use different types of exercises: isokinetic, which are high speed movements with resistance; isometric, where you contract your muscles without moving the joint; eccentric, which focus on lengthening the muscle; and then co-activation exercises, where you activate the muscles on both sides of the joint at the same time.
So you're basically working on strength, control, and coordination. What about techniques that specifically target that unconscious reflexive control?
That's where unconscious training comes in. So things like reactive muscle activation, RMA, which is all about improving those fast automatic responses. For example, for someone with an SLIL injury, they might focus on reducing activity in the extensor carpioulnaris muscle, ECU, which can make the instability worse, while strengthening the flexor carpioulnaris, FCU, and the extensor carpi radialis longus, ECRL.
Okay.
Those help to stabilize the scaphoid. And the sources even mention something called the dart thrower's motion, which is a specific movement that's good for SLIL injuries because it promotes stability. And then there's the power ball, which is that gyroscopic thing you spin in your hand
Oh, yeah.
that helps stimulate those reflexive muscle activations.
So you're working those muscles without even thinking about it.
Right, exactly. It's all about those reflexes. And then there's some research that's been done on specific rehab protocols, which is really interesting.
Yeah, what can we learn from those studies?
So one study in 2024 looked at 39 people with different types of carpal instability. They all had it confirmed on imaging, and they were having symptoms. They did a rehab program for 6 to 8 weeks, 2 to 3 times a week, and they measured their progress using the VAS, which is a pain scale, and the DSH, which measures disability in the arm, shoulder, and hand. And the great news is that they saw significant improvements in both pain and function after doing the rehab.
So that's really encouraging. It shows that these rehab programs actually work. What about the other programs I mentioned?
Well, there was a 2020 program that focused on people with chronic wrist pain and midcarpal instability. They really emphasized improving sensory motor control, using visual and tactile cues to make people more aware of their movements.
Oh,
And they included strategies for pain management and improving reflexes. And then in 2017, there was the Birmingham program, which was a smaller study of 6 patients with early stage SL instability. Their rehab had 3 phases. First, they worked on conscious control and isometric exercises. Then they did low load balance exercises. And finally, they did high load plyometric exercises, which are those quick, explosive movements. And they got positive results too, with improvements in grip strength, DASH scores, and pain.
so it sounds like no matter what type of carpal instability you have, rehab is super important.
Yeah, I mean, these studies really show that a good rehab program can make a huge difference. And it's not just about strength and range of motion, it's about getting that proprioception and neuromuscular control back.
Right, that mind-body connection again.
Exactly.
Well, this has been a fascinating look at carpal instability. It's really made me think about my wrists in a whole new way.
Yeah, me too.